I would like to start this lecture with a case. A 65-year-old female comes to the clinic with recent onset of back pain after a slip and fall while climbing stairs. She attained menopause at age 42 and her mother has a history of hip fracture. She has a history of asthma and uses high-dose steroids during exacerbations. She has hypothyroidism for many years and lactose intolerance. What are her risk factors? She has many, and she looks like a regular patient that we would see in our office. She attained early menopause, which is something that's common here. And mother with a history of hip fracture, if we ask, I'm sure people will come out with mother having a history of hip fracture or vertebral fracture. And high-dose steroid use for asthma. Even recently, last week, I saw a patient who had been on steroids for 25 years and came to me for obesity and unable to get off steroids. And hypothyroidism, which is such a common disease that we treat with thyroid medicine. And hyperthyroidism, excess thyroid is associated with bone loss. But I put hypothyroidism because it's more common. Many times patients go on thyroid hormone, excessive doses, and don't go for follow-up. And that's a risk factor for bone loss. And lactose intolerance. So the risk factors, like we mentioned, all of these, and reduced calcium intake and vitamin D deficiency, probably due to lactose intolerance, or avoiding dairy products, which is a major source of calcium. And many times when you talk to patients, they say they don't drink milk. I don't know what happened to the old-fashioned way of drinking milk and having curds, and no exposure to sunlight, with more and more people staying indoors and avoiding the sun, and excess thyroid. So it's such a common problem. I'm sure all of us will come across in our practice, whatever our specialty is. Why talk about osteoporosis? Why is it so important? You look at the y-axis, cases per year, osteoporotic fractures, heart attack, stroke, and breast cancer. And it's a huge number. I know it's not as serious as any of these illnesses that we immediately jump on, but here we have a huge volume of patients with osteoporotic fractures, and more people are living longer, especially the women. And so the healthcare costs, the morbidity and mortality, and that's why it's important we do something about this. What about osteoporosis in India? An estimated 25 million Indians, and the number varies to 30 million in some reports. Osteoporotic fractures in India occur commonly in both sexes and occur at a younger age than in the West. And there is widespread vitamin D deficiency across India at all ages and in both sexes, particularly in the urban areas. And this is the projected global distribution of fractures. This is in 1990, Asia, 31%. And in 2050, the projected is 51%. So more than half of the global distribution of fractures is occurring in Asia, and India is next to China. So we have a lot of patients suffering from osteoporosis, not knowing, and unless we think about it and do the testing and talk to patients whenever we get a chance, we are going to have a significant problem in our hands. And what is this osteoporosis continuum? You start with a healthy spine, and a woman goes through menopause, 50, experiencing vasomotor symptoms, and then 5 years later, she's at greater risk for vertebral fracture due to bone loss. And I say 5 years is because the first 5 to 10 years after menopause is when we have a significant bone loss, and that is the crucial time for us to talk to women. And then, if left untreated, undetected, becomes kyphotic due to multiple vertebral fractures, and you see the contrast between this spine and that spine. And why it happens, so if we can look at the bone mass life cycle in women and men, this lighter graph is in women and the darker one in men. This is x-axis, we have the age in years, and here we have the bone mass. We all increase our bone mass throughout childhood, particularly through puberty. There is a significant increase in bone mass, and there is a peak bone mass that's attained in the 20s and early 30s. And then in women, you see this around the menopause time, there is a steep decline in bone mass, which is the reason for osteopenia and osteoporosis and continuous bone loss. In men too, there is this bone loss, but it's gradual. And many of these factors are involved in attaining peak bone mass and this loss. So we can do something about osteoporosis here or here. This is looking at the standardized hip BMD in white women at every decade, starting from 25 to 85. The dark green is the green is the osteoporosis, and this is osteopenia, and blue is normal. As you see, we have less of green. Between 45 and 55, there is a little jump. And beyond that, there is this huge jump. And this is the place that we have the opportunity to intervene. And how is osteoporosis defined? It's a skeletal disorder characterized by compromised bone strength, predisposing a person to increased risk of fracture. Bone strength reflects two entities, bone density and bone quality, about which we'll talk about in some time later. This is the normal bone. You see a lot of connectivity, thick trabeculae, and this is the osteoporotic bone, where you can see a lot of empty spaces, no trabeculae, trabecular fracture, thin trabeculae, and this cannot sustain a trauma. So bone strength equals bone quality and bone density. This is what we can measure by the clinical tool that's available today. And this is something we don't have a way of measuring, but I think we have to keep this in mind when we talk to a patient with a bone density report. So here, bone quality, microarchitecture, degree of mineralization, collagen properties, all of them play a role. Now, looking at the various fractures and the incident rates in postmenopausal women, at age 50, the vertebral fractures start to rise right away, and then it keeps on going up. The wrist fractures, they go up, and then they kind of peak around 60, and then plateau. The hip fractures occur much later. So we have to be looking to prevent these fractures depending upon what age the patient comes in. And hip fractures cause significant morbidity and mortality. And the 1-year mortality after a hip fracture is 20%, and permanent disability 30%, and unable to walk independently 40%, and 80% of them will be unable to carry out more than one independent activity of daily living. Unless, we talk to hip fracture patients, they might have had surgery, physiotherapy, walking, doing everything, but still they may have some limitations in their daily life. And they are not the same after a hip fracture because they're afraid to fracture another bone and do not do the things that they have been doing before. So we are talking about quality of life. Imagine a patient having a hip fracture at 70 and living through 85 or 90, and that's what we have, and it's easily preventable, and that's what we have to think about. And this is again looking at vertebral fractures. We have to, whenever we do x-rays, we detect them, but even before they occur, we have to prevent them. This is a smiled fracture, and we should not miss this when we see this. And this is a classical severe wedge fracture, wedge compression fracture. And what happens after vertebral fractures? There is a lot of morbidity, back pain, loss of height, kyphosis in severe cases with multiple vertebral fractures, and loss of pulmonary function because the lungs are really squeezed and they cannot, and the function is reduced, and they may develop respiratory problems. Diminished quality of life. This is what we are talking about: dependence on medication, sleep disorder, depression, and loss of independence. So even though it looks like a very minor problem, not a serious one, it can lead to so many other issues. Now we move on to case 2. 55-year-old female with history of back pain went to a camp where she had BMD by ultrasound and was advised medication for osteoporosis. She is concerned about this diagnosis and about her increased fracture risk. She does not want to take medications on a long-term basis and seeks your advice. Does she have osteoporosis? This opens up the discussion on how to detect osteoporosis. Ultrasound is not the best modality now, at least now, because it has to be standardized. In standardized centers, it still may be a good clinical tool, but in the camps, when they do ultrasounds, especially peripheral bones, it's not an accurate measurement, and it can be wrong either way, overdiagnosing and underdiagnosing. And I would not make a diagnosis based on that. I would still go and do DEXA. And we have to do a DEXA, dual energy X-ray absorptiometry. And in this patient particularly, because she's quite young, we have to look for other risk factors. Why she is having osteoporosis. Should not say every postmenopausal woman having osteoporosis is all due to hormone related bone loss. And how to diagnose is by using DEXA. And this is the GE Lunar, and there is another Hologic machine. It's such a simple test. That's why I put this picture for you to know that we can explain to the patients it's not another scan. They might have gone through CT and MRI and whatnot. But here the patient will comfortably lie on the table, and this is the X-ray arm. There are two different types of X-ray beams that are focused on the patient. It's just the positioning of the patient that takes time. The actual scan itself is 5 to 10 minutes. We routinely do lumbar spine and left hip, and only in certain situations we do forearm. And the images are sent to this computer, and we get an immediate printout of their results. What are the indications of DEXA? In women age 65 and older, and in men age 70 and older, we need to know their bone density for sure. In men 50 to 69, and in any postmenopausal woman with risk factors. So we need to talk to the patients to go through a list of risk factors, which are multiple, so from early menopause to steroid use to various other medication use, other endocrine conditions like hyperparathyroidism, hyperthyroidism, and hypercortisolism, rheumatoid arthritis, and so on. And again, in people with malabsorption syndromes, we need to worry about bone loss. In anyone with a low trauma fracture or a significant fracture, we need to consider doing a DEXA. And before initiating treatment, I have seen this, patients have a fracture and they go on a medication. How do we know whether they have osteoporosis and the fracture is due to that? Or we need to know their baseline in order to follow them. We do not put a patient on a medication for diabetes or cholesterol without checking their baseline. And then we can use this tool for monitoring BMD and treatment every 1 to 2 years. And how do we diagnose osteoporosis? This is the WHO osteoporosis classification. In the printout, we have multiple numbers and multiple information. The one thing that, we look at every little detail, but the one thing I think that we should look at is the T-score. If it's more than minus 1.0, it's normal. Between minus 1.0 and minus 2.5, it's osteopenia. If it is more negative than minus 2.5, it's osteoporosis. And it's so practical to do a DEXA, and accuracy and precision are excellent, shown by multiple studies for diagnosis and for treatment and follow-up. Radiation exposure is very low, and you can measure multiple skeletal sites. And it's very safe, short investigation time, and ease of use. And the radiation exposure is about 1/10 that of a standard chest X-ray. Just to give you an idea, this is the effective radiation dose in microsievert units. And here is a 1-day natural background. And here we have the chest X-ray. We have lateral spine X-rays, which we use to look for vertebral fractures. And here we have the DEXA, QDR 4500. So it's very minimal for the two sites that we are looking at. Now I'm going to move on to the vitamin D part of things in diabetes. We'll start with this case. A 51-year-old female comes with generalized body pain for the past 6 months and now worse in the past 2 weeks. She has a history of obesity, diabetes, hypertension, now status post-bariatric surgery 2 years ago. She has lost 25 kilos and currently only on diet and exercise and discontinued medications for diabetes and blood pressure. She has some abdominal cramping and loose bowel movement at times. She is 4 years postmenopausal. How would you proceed with her evaluation? So this is a patient that you probably will see. There are so many risk factors looking at you. Postmenopausal, bariatric surgery, having abdominal cramping, loose bowel movements. I know I already told you that I'm going to switch to vitamin D, so we want to look at vitamin D. So you would want to check a calcium, phosphorus, albumin, and alkaline phosphatase, and a 25 hydroxy vitamin D level. You have to specify that, and a PTH, just to know what is happening with her bone profile. Many times I'm surprised to see, in this patient probably she would have a low vitamin D level, and many times a patient where, comes in, a postmenopausal woman comes in with low bone density, but I check a vitamin D every time and I find a low vitamin D level. And here this patient probably will have a low calcium, low phosphorus, and a low 25 hydroxy vitamin D level, and maybe a high PTH. It's probably it's very well known with bariatric surgery there is the initial bone loss. That's one. And the second thing is she probably has an element of malabsorption and vitamin D deficiency. So this is a patient we want to check that and treat her appropriately. So in India we have plenty of sunshine, and there are an average of 28-56 hours of sunlight per year with an average of 7.8 hours of sunlight per day. But over 50% of healthy Indians have poor vitamin D levels is the report as early as 2003. And Indians get enough of sun but not the sunshine vitamin. And there is this global, and it's not only India, it's global. We are talking about India because of the sunshine that we have, and low levels of vitamin D in South Asia, Middle East. And again, Dr. Mittal, I've listened to Dr. Mittal presenting vitamin D deficiency, which is present from neonates to elderly. And this is another report on North Indian village, 25 hydroxy vitamin D deficiency. Now let's look at the metabolism of vitamin D. What happens is, with sunshine, the UVB rays help conversion of 7-dehydrocholesterol in the skin to pre-D3 and vitamin D3. And then at the level of the liver, it's hydroxylated by the 25-hydroxylase enzyme to 25-hydroxy D3. And this is the most stable form of vitamin D, and that's why we use it for estimating vitamin D status. And then at the level of the kidney, we have this 1-alpha hydroxylase, and then it becomes 125-hydroxy D3, which acts at the level of the intestine, enabling calcium absorption, and at the level of the bone, calcium resorption. And again, PTH plays an important role here, which regulates the normal serum calcium and phosphorus. So it's a very integrated mechanism. And until a few years ago, we have been thinking vitamin D and bones and osteomalacia, rickets and osteoporosis. But now we know at least that there is a role of vitamin D in human body beyond bones. Bone health, muscle power, immune system, skin, cardiovascular system, and diabetes. Now, from many of the studies that have been done in the past several years, we know there is contribution of vitamin D to health overall, affecting many systems. You look at the physiological systems, all cells, biological response being cell proliferation inhibition, so low levels associated with cancer. I use the word associated. I think that we have to keep in mind. This is all association. Different types of cancer, calcium homeostasis, we know rickets and osteomalacia and osteoporosis. With immune system affecting T cell function, increased prevalence of infection and type 1 diabetes, autoimmune diseases. Pancreas beta cells, it facilitates insulin secretion, and it's been shown, and so it is association with impaired glucose tolerance, type 2 diabetes has been shown. And at the level of the heart and CVS, renin-angiotensin regulation, so high renin hypertension, increased cardiovascular risk. And muscle, which is very important to osteoporosis and bone health. It promotes muscle development and muscle strength, otherwise increased falls. And we have to remember osteoporosis doesn't cause any problem until the patient falls. So we have to work on preventing falls, which we will again talk about. So thus we have this old and new information, classical and non-classical effects of vitamin D, which is an emerging concept, no conclusions yet. Now, the optimum level is anything above 30. Insufficiency between 10 and 30, and there is, we are coming to as low as 20 now to call optimum, and deficiency below 10. And we talked about these long latency diseases, and we know about osteomalacia and rickets. And this just gives you the list of causes of vitamin D deficiency and some of the associations. Now, causes, I mean, sunscreen probably now more and more, we are, even though we have the sun, we are first of all indoors, we are not outdoors. And we do use a lot of sunscreen in some forms, lotions and creams and whatever else. And medications, anti-seizure medications by interfering with vitamin D metabolism, glucocorticoids is very well known, and hepatic failure, renal failure, of course, and malabsorption. Anyone with malabsorption, some constant GI problems, we need to think of vitamin D deficiency. So in these situations, it is worthwhile thinking about vitamin D deficiency. And these are all the multiple effects that have been seen to be present with vitamin D, low vitamin D levels. So the importance of vitamin D in cardiovascular disease and diabetes, just this is looking at a glance. With deficiency, there are studies that show insulin resistance and beta cell dysfunction associated with deficiency, resulting in diabetes and metabolic syndrome. And with deficiency, we have secondary hyperparathyroidism. We know it has implications with inflammation, atherosclerosis. At the level of the kidney, by the renin mechanism, hypertension, hypertrophy. So why this expansion of vitamin D knowledge? You look at the PubMed hits on vitamin D over the years. The interest started to show in the 80s and early 90s. And then, you know, there is this significant interest in vitamin D studies, not only because there are more and more studies that are out there, and there is more and more interest from various areas, as we looked at various systems that were associated with this vitamin. Now you can, I mean, I'm not even going to look at, you know, all, I mean, I cannot justify if I start to talk about all the studies, and you can go and look up bone and cancer and renal failure and diabetes and so on. There are so many studies that are out there. There is so much evidence, but what do the evidence suggest? Before even I go further, I'm going to show you why we have this interest, the few observations that led to this interest, but I'm not showing the negative studies here, but there are some associations, some studies show a negative association. So the final conclusion is, it's not clear yet, unless we do long-term studies, very well controlled, randomized, comparing the two groups, looking at endpoints. We cannot conclude at this time that there is a strong relationship. Now here, this is a study looking at diabetes care. This is from Diabetes Care 2010, looking at all-cause mortality and cardiovascular mortality in 289 type 2 diabetic patients compared to low and normal vitamin D levels. It's high in the low vitamin D group. And this is the famous Nurses' Health Study observation, where what they found is a combined daily intake of 1200 milligrams of calcium and 800 IU of vitamin D, which is what we recommend, is associated with a 33% lower risk of type 2 diabetes compared to a lower intake. So this suggests potential beneficial role for both vitamin D and calcium intake in reducing the risk of diabetes. So you should read the terms potential, beneficial role, and it is a suggestion. The effect of oral vitamin D and calcium replacement on glycemic control. Here, what they have looked at is by replacing calcium and vitamin D and normalizing the levels in patients with type 2 diabetes, it causes a significant decrease in hemoglobin A1C and weight, which they attribute to increase in vitamin D levels. And this is one of the earlier studies looking at hypovitaminosis D and insulin resistance and beta cell dysfunction. Increasing vitamin D levels from 10 to 30 improves insulin sensitivity by 60%. So it shows a positive correlation with insulin sensitivity and negative effect on low vitamin D level association with beta cell function. And this is a publication from 2009 where they looked at a double-blind randomized placebo-controlled trial. In this, they looked at short-term effect of vitamin D3, only 6 months. And they gave 120,000 units fortnightly, and they found improvement in oral glucose insulin sensitivity, centrally obese but non-diabetic. So the implications are it has got something to do with insulin resistance, something to do with lowering the risk for diabetes, even pre-diabetes. But we don't know clearly if this is a clear cause and effect. So the optimum vitamin D levels are ideal more than 30, acceptable more than 20, insufficient 10 to 20, and deficient below 10. And sorry. I can't believe it's not showing up. This is the most important slide. It was showing up in my computer. This is the dietary reference intake of calcium and vitamin D. Now, in childhood, the calcium intake should be 1,000 milligrams per day. And when through pubertal years, when there is increase in bone mass, it goes up to 1,300 milligrams per day. And then, and during the adulthood, it's 1,000 milligrams. And in postmenopausal women, it's 1,200, and older men, it's 1,200 milligrams. That's the calcium requirement. With vitamin D, the recommended allowance is 400 at a younger age group and 800 in older age group. But when you look at the minimum desirable level of 25-hydroxy-D, which clusters between 28 to 32, the average intakes of at least 800 to 1,000 units per day of vitamin D3 is required. Especially now here that we see so much of vitamin D deficiency, we would not go wrong by giving 800 to 1,000 units of vitamin D to everyone, particularly postmenopausal women. Now we move on to a fourth case, 33-year-old female with history of pain affecting shoulders, knees, back, chest for over 2 years. This is a patient that I saw in my clinic and unable to walk in the past 2 months and crying due to pain during her clinic visit. Her reports show vitamin D levels less than 4 multiple times in her file, PTH high, low calcium and phosphorus. She was given Rocaltrol for a brief period and she was taking calcium intermittently. And because of the high PTH level, she also had a system AB scan which was negative. This is a scan that is used to look at hyperparathyroidism. Now, what does she have? It's so obvious she's having significant vitamin D deficiency and secondary hyperparathyroidism. Now, was she optimally treated? She was given Rocaltrol, which we know is 125-hydroxy dihydroxyvitamin D, which is not the best way to replenish the vitamin D stores in our body. And the calcium was not also given regularly. So she never got corrected. And for a simple vitamin D deficiency, she was going around to different doctors and multiple lab tests. And so how to treat this woman? We would give vitamin D3, high dose, 60,000 IU, that's what is available here as sachet form, once a week for 8 weeks. Again, depending upon the patient's level, this is such a low level, so you want to give this much, and you can tailor your treatment. And calcium of 1,000 milligrams per day. There is no point in giving vitamin D3 not calcium or calcium without vitamin D3 because you won't have the absorption. So how do you follow up these patients? She had pain relief after a few weeks of treatment, and that's a significant sign. And I would always check a vitamin D level, but here the vitamin D level to check is very expensive, and that's why people don't check it. We know in many conditions, particularly diabetes or cholesterol or any other illness, the compliance is always a significant problem. When a patient comes with pain like this, they probably will take it regularly. And moreover, you want to know that you have done something about it. So in this patient especially, I would check a vitamin D level to see where she is at, whether she needs long-term vitamin D supplementation. And this is up to the endocrinologist story about whether we need to recheck her PTH to make sure it's only secondary or something else. Now, just a few words about diabetes and osteoporotic fractures. Diabetes and osteoporotic fractures are two of the most important causes of mortality and morbidity in older subjects. There is increased risk. And there is a close association between fragility, fracture risk, and diabetes of both type 1 and type 2. Type 1, there is reduced bone density. In type 2, there may be normal or increased bone density. And there is this apparent paradox, and why. At a given level of BMD, diabetic patients may have lower bone quality with respect to non-diabetics, as shown by several studies. That is why, by doing a DEXA, we are just detecting their bone density, and if it is normal, it doesn't mean that we are reassured and she's not going to fracture. So we need to think about this bone quality issue. And at the research level, there is a lot of hope, and there are ways of measuring bone quality. Actually, a three-dimensional look at the bone, and looking at what I mean by bone quality is we look at trabecular number, cortical thickness, all those minute details, which are the fundamental reasons why someone would fracture. And there are these various mechanisms why the bone quality may be low: deposition of advanced glycosylation products and collagen, reduced serum levels of IGF-1, hypercalciuria, renal failure, and so on. And we have to remember this. This is a very important thing that we have to remember. The propensity to fall and several comorbidities which causes the higher fracture incidence in diabetes patients. So they have a tendency to fall, and I did mention to you that patients with osteoporosis are at risk for fracture only when they fall. So that's why if you have a T-score of minus 2.5 in a young 50-year-old for whatever reason compared to an 80-year-old, it's not the same risk, fracture risk. But the report will say, based on the T-score, this is the fracture risk. But as physicians, as we always do, we have to think about that particular patient as an individual, look at all the other factors involved with respect to their fracture risk, and decide who is the one who needs aggressive treatment, and fall prevention, counseling. I talk to patients, I tell them, you cannot fall, and they just laugh. And they say, you know, why am I going to fall? But we have to stress that point and talk about fall prevention strategies at home, and so they don't sustain a fracture. As this bone density has come down over so many years, it's going to take some time for the bone density to improve as we treat them. And in that period of time, they are at risk for fracture. So with diabetic patients, we know why they are at risk for fracture. Probably due to fluctuating blood sugars, blood pressure, treatment. These medications are a big reason for imbalance, loss of balance. People are on sedatives, retinopathy, so poor vision, many other comorbid conditions, someone with a stroke, recovered but still not having quite the same strength. So these are all the things that we have to consider when we are treating a diabetic patient. That's why there is increased risk of fractures. So I would be aggressive. But what should you do when you see a diabetic patient with, what should you do about their bone health? First of all, we do the close glycemic control, which is something that we always do. Adequate intake of calcium and vitamin D depending upon where they are, age-wise. Screening for low BMD as appropriate. Prevention and treatment of complications of diabetes, and which we are going to do anyway, keeping in mind that's going to prevent the falls and fractures. And attention should be paid in treating diabetics with thiazolidinones in women with type 2, particularly if elderly, because there is this association with fractures and low bone density. And patients with osteoporosis and diabetes should be offered the same pharmacological treatments as non-diabetics. And there aren't many studies which have looked at non-diabetics per se to say whether it should be different or not at this time. So, like Dr. Santana mentioned in one of his talks here, Prevention. Every talk, I think we should finish by saying prevention. Because if we prevent, then we don't have too much to do with diagnosing and treatment. So as we are diagnosing, treating, and looking at the risk factors, the preventive measures is very, very important. Here this focus is on vitamin D and calcium. At least that we have to focus on. So sunshine, calcium-rich foods, which is mainly dietary intake, milk, curds, cheese, and supplementation to lactating mothers, because osteoporosis is known to happen in lactating mothers and fractures even, and fortification of infant food products, and making physical training to children in the schools compulsory, and outdoor activities of the elderly and aged. We know we don't do this anymore. We don't drink this anymore. We don't do much of this anymore. Even the children at school, they do very little of physical training. And we do this, use a lot of sunscreens. So we are really not utilizing, banking on the sunshine we have. Maybe we still have problems with metabolizing vitamin D at the skin level. But I think we should take these preventive measures. And so vitamin D, like Michael Hollick put it, a delightful health perspective. Sunlight provides most humans with their vitamin D requirement. And insufficiency has been linked to a wide variety of chronic diseases, as we saw, and a supplementation of 800,000 units per day are needed. And so we have to plan for this in 21st century. And so one more reason to love summer, vitamin D to overcome sunshine deficiency. Thank you.
That was an excellent lecture. I'm sure this would evoke a lot of questions from the audience.
Madam, as a diabetologist or as an endocrinologist, would you recommend vitamin D for all your diabetic patients? First question.
That's no, because not really. Wherever you have suspicion.
Yeah, because vitamin D is known to be more effective for treating the diabetes as well as for reducing the dosage of the anti-diabetic agents. Is it true?
See, I'm not sure. With the evidence that we have, I'm not sure of that fact. But in people who have reasons for vitamin D deficiency, not diabetes per se, but other reasons, then I would definitely check vitamin D and treat it. Right now, we don't have conclusive evidence. That is the reason we are not recommending such widespread checking of vitamin D and treatment.
Secondly, in Western people, is it true that they have got the capacity to produce more of vitamin D, 6 times than the black people? Is it true?
It is a problem, because we do see vitamin D deficiency in India and Africa despite so much sunlight. And there is a problem relating to the pigmentation of our skin in synthesizing vitamin D also.
Is it true that they are producing 6 times, they have got 6 times efficient production of vitamin D?
I don't know about the exact. I can't
have read in one journal.
Okay. I will look up. Yeah. Contraindications? Not really. I don't think of, I'm not able to think of anything unless, one thing I want to do, a practical point, patients are on multi-formulary and they are taking different vitamins, different supplements, and so you want to look at what they are taking, and one is for neuropathy, one is for something else, and if they're overdosing on vitamin D already, then you don't want to give more. But you have to carefully look at their calcium intake and vitamin D intake. But again, whenever I say 1000 milligram or 1200, it's diet plus supplements. So many supplements contain vitamin D, many supplements contain calcium. So we want to not overdose people and cause vitamin D toxicity, which is very rare to occur, but I don't see a contraindication.
Excuse me, madam.
In hyperparathyroidism, you still have to give calcium and vitamin D. Not too much, the recommended amount.
I have two questions. One is, there are many calcium formulations are available in the market. Calcium carbonate, so many formulations. So which one is better? And next, in many laboratories, instead of doing the complete DEXA, they screen the only radial bone. So is it really worth to screen the radial bone and to know the level of osteoporosis or osteopenia? Is it sufficient?
The two excellent questions. One is we have various preparations, calcium carbonate, citrate, and many others. Calcium carbonate is something that we tend to use more. This should be given after food. It needs the acid in the stomach for absorption. But if you do have patients who have achlorhydria or on antacids, H2 block, proton pump inhibitors, then maybe citrate is preferable. Regarding the second question, it's an excellent question. The DEXA, the standardized two sites are lumbar spine, L1 through L4, and femoral neck and total hip. And so other than these two sites, you cannot just do a radius and conclude a person has osteoporosis. And the vertebral bone is made up of more of trabecular bone, which is the bone that is sensitive to estrogen loss. And so in women, it makes sense to look at lumbar spine for sure if you have any limitations for hip. But if in the left hip there is any surgery or any other significant arthritis, the positioning is difficult, then you can move to the right hip. There is, the radius is always done in addition. In situations like hyperparathyroidism, where it is more of a cortical bone in the radius, we want to know if patients have increased bone loss there. Or in a patient who has had a laminectomy, who has had bilateral hip procedures, you have only the radius, it's worth doing that. But otherwise, you have to look at lumbar spine and the femoral neck and total hip. And the total body is not needed for osteoporosis reasons. It's for assessing lean mass and body fat and various other purposes. Renal stones, the patient that I showed you, also have renal stones. I think, we have to assess their stone content for sure to know if it is calcium related. And you want to check a 24-hour urinary calcium to see if they are excreting too much calcium in the urine. If not, I don't think the stones per se is a reason to prevent you from giving recommended doses of calcium and vitamin D. But in the patient that I showed you who was given Rocaltrol, there is increased risk of hypercalciuria and renal stone formation. So that's why giving Rocaltrol, it's a risk. And it doesn't solve the problem, yet it can cause hypercalciuria. And so there you have a problem. But just giving the recommended daily allowance of calcium and vitamin D or treating a deficient patient should put you at risk for kidney stones.
Thank you very much for Madam for focusing on such a world crisis. It's not only in India, it is everywhere, it is all over the world is one of the many. Madam, everybody is bothering about the renal calculus. But in India, the older peoples and females are more prone for disc prolapse and fracture femur in the old age. So, in US, they are doing ambulatory bone density measurement. Here it's available. It is feasible to our government. Okay.
You are talking about ultrasound or peripheral DEXA, I'm assuming?
Peripheral DEXA.
Yeah. Yeah. See, we know central DEXA is the recommended clinical assessment for osteoporosis. So I would base, if I have to make a diagnosis and treatment recommendations, I would do a central DEXA looking at the spine and hip. I would not base it on just the peripheral heel DEXA or an ultrasound measurement for the reasons.
Heel DEXA is taking in an ambulatory manner. They are taking, madam.
We don't know if it is accurate.
Useful.
Yeah,
it may be accurate.
Yeah, I don't know if it is accurate. So
but without after some age, we can put vitamin D and calcium. It will not affect the patient, madam. After some years, after menopause, after 45 years of female, they are more prone for osteoporosis.
Right.
It's a very great menace,
Right.
especially for females. Everybody used to have osteoporosis and osteoarthritis.
you have brought up a good point. Osteoporosis is not a disease of old age. It's something we have to think about from childhood. Giving calcium, increasing physical activity, it's very, very important, because if I showed you the peak bone mass attainment, if we can do that better at a young age, then that will help with compensating for the bone loss that's going to happen later on. And believe it or not, when I was training, I had to go and give a talk to Girl Scouts on osteoporosis, just teenage girls. And the kids were just giggling, why am I even talking about this? And then as we went along and talked about calcium and vitamin D, they were so interested, and many of them didn't know about it. And so it's important we start preventing osteoporosis from childhood and mainly adolescence, and then, focus on diagnosis and prevention at perimenopausal age for sure.
What is the role of estimating serum calcium level in the blood to exclude this osteoporosis or osteopenia?
The serum calcium level, it's, as you know, it's dependent on multiple factors. Our level of hydration, vitamin D levels, the intake of calcium, it's a lot, it's just not that simple. You need to, the serum calcium level can be normal many times with vitamin D deficiency. In this patient with such low levels of vitamin D, I saw a calcium level of 8. But many times we see vitamin D level of 12 and calciums being normal. Again, the calcium level is dependent on the albumin in the body. And so I just wouldn't just check a calcium level and know whether I need to give calcium or whether they are at risk for osteoporosis.
Should
osteoporotic phase. What about the DEXA? If I do DEXA, it will, how before we can find?
Yeah, it will detect much early. By the time you see osteoporosis in the X-ray, significant bone loss has occurred. So, and again with X-ray, it's not a perfect tool. It depends on the beam penetration. It can be light, it can be dark. If you see a fracture, yeah, it's useful. But I wouldn't diagnose osteopenia or osteoporosis based on X-ray. I wouldn't wait that long. I would do a DEXA, know exactly where the bone density is. And then, between minus 2.5 and minus 4, you may not know the difference in an X-ray. But it is significant for us to address fall prevention or treatment, use which treatment agent we want to use in that particular patient, because we have very many treatment